होटेल सिरजा रे अच्छु होटेल सिरजा सेंटर रे आज आम डॉक्टर मान द्वारा गोटे शुभारंभ कार्यक्रम गोटे करा जाउछे आम आजिका देखमा चल डॉक्टर मान द्वारा भवानीपाटना टाउन डॉक्टर मान द्वारा खास कर देखबार के गोटे स्पेशल कार्यक्रम करा जाउछे। आज एन कार्यक्रम कॉन्फ्रेंस रखा जाउछे सब सार माने संजय दास, रमेश कुमार, सुरेश कुमार, जगुलाल अग्रवाल, दीनबंधु साहू, शरद चंद्र सिंह और तार संगे आमर हरिश्चंद्र सार, कविराज चौधरी सार, कृष्णाकर, साधुचरण पंडा सर, डीटी महांती, हरे कृष्ण सतपथी, लंबोदर साहू, लोमोपड़ा नायक तो सार मानकर आज प्रेजेंस बहुत बड़ कॉन्फ्रेंस गोटे होबार के जाऊे आम चल आज कॉन्फ्रेंस स्टार्ट होबार के गलाना तो भीतर के चल जाऊँ आउ देखमा।
Welcome you all to this conference of RSSDI. Today is proud and historic moment for us as this prestigious academic conference as a distant dream is now becoming a reality. For that, I am expressing my gratitude to the state leadership of RSSDI for giving this opportunity to host this conference. I also, my heartfelt thanks to the organizing committee, the scientific committee, the sponsors, volunteers who made this event possible. I wish this midterm conference a grand success. Thank you.
Now I hand over mic to our HOD sir to say a few words in brief.
Good morning to all distinguished delegates and faculties. Today we are proud of that RSDI state branch allowed to conduct a midterm CME in the soil of Manikeshwari, that is Bhavanpatna, which is very remote, and the academic or scientific activities. Now to be started, though it is delayed now, and all learned, our research fellows will clarify and at least give vision to our doctors of all disciplines, because diabetes is a syndrome that affects the all system of the body, that not only endocrine or physicians are concerned, but all departments, from beginning from neuro, derma, gynecologist, ophthalmologist, all are the headache. Diabetes is the headache to all discipline while treating to the patient. So at least newer visions or newer scientific research what is going, at least to be apprised to our a newcomer or doctor of Kalahandi, specifically from district, they will be aware of and they will make a awareness among the people of Kalahandi, which is tribal and innocent peoples. I am pleased here it is easy to take the people of Kalahandi, not in coastal area. The coastal area people or patients are difficult to manage but the people of Kalahandi very innocent and they will be benefited by this academic activity. With this, I hand over to my.
Thank you, sir. So, as the organizing secretary, I welcome all the august audience, our esteemed speakers, chairpersons, the pharma people, the media brothers, and all the associated persons. I heartily welcome all of you. Very soon we are going to start the scientific program. We are already late. Scientific program, each session, we are having 3 speakers, and every speaker is allowed 20 minutes. Out of 20, they have to complete their talk by 17 minutes, and another 1 minute is a grace time, then another 2 minutes for discussion. So please cooperate. We are already late. We don't waste time. Let us start the scientific session. Thank you all. Once again, my gratitude and thanks to each of you. Thank you, sir.
Thank you. Thank you so much, sir, for this wonderful address. It's such a fortunate moment having your presence here. And without wasting any time anymore, I welcome Dr. Shritam and Dr. Anvesha on the stage for the beginning of our plenary session number 1.
Namaskar. Good morning, everyone. Now, I would like to invite Dr. P.K. Sahu sir, Senior Consultant and Physician. And next, Dr. Jagulal Agrawal sir, Organizing Chairman, Diamid 2026 and Senior Consultant Physician. Sir, please come on stage.
Dr. S.K. Bansal sir, Secretary RSSDI, Odisha State Chapter, Senior Consultant Diabetologist. Dr. Malti Murmur ma'am, Professor and ex-HOD, Department of Medicine, Bhimsar, Purla. Sir के mic.
Ready? Aku. हाँ सर पोडियम का ओके मुझे साला पर मांगे So let's not delay this session anymore. As we are already running late, let me introduce and call our first speaker, Professor HOD, Dr. Sarat Chandra Singh sir, Department of Medicine.
So, good morning, everybody. I, on the behalf of my co-chairpersons, welcome you all to this midterm CME of RSSDI held at Bhavani, Patna for the first time. So this is an opportune moment. Much has been said about this diabetes, but only one thing I will be talking about this, just a half a minute of your time, that we are a country with the largest number of diabetes, roughly more than 110 million people with diabetes. And for the comprehensive care of diabetes, all physicians, all doctors who care for patients with diabetes must have an updated knowledge, because a lot has been changing. Every day there has been change in the guidelines and the treatment perspectives. So it is an opportune moment for all the doctors present here to update their knowledge and acquaint themselves with the latest technology, latest things, how to manage cases of diabetes. In this context, and I would like to just mention one thing only. At one time, Kalahandi was infamous for malnutrition. And you will not be surprised to listen that malnutrition has a role to play in diabetes. So this is going to be very interesting. And before we start on any disease, we must have a clear classification and we must know the pathophysiology before treating any disease. So in this context, we are going to start our topic, and the topic will be dealt by none other than Dr. Singh. And he is a well-known figure in the area. And he will be telling us about the pathophysiology and newer classifications of diabetes. Over to you, Dr. Singh.
Regarding just a little bit about the introduction, I have just collected data from various sources, and I will just start. Diabetes mellitus is a group of common metabolic disorders that share the phenotype of hyperglycemia caused by complex interaction of genetics and environmental factors, resulting in a reduced insulin secretion, decreased glucose utilization, and increased glucose production. So, the metabolic dysregulation associated with the diabetes mellitus causes secondary pathophysiology changes in multiple organ systems that impose a tremendous burden on the individual with the diabetes and on the healthcare system. Diabetes mellitus is the leading cause of, everybody knows, the end-stage renal disease, non-traumatic lower extremity amputation, adult blindness, cardiovascular diseases, and others also. What are the epidemiology and global consideration? Just these are the data. The prevalence of diabetes mellitus type 2 is rising much more rapidly, presumably because of dietary changes, increasing obesity, reduced activity levels, as countries become more industrialized and aging in the population. The countries with the greatest number of individuals with diabetes, that is by 2024, it was China followed by India. Globally, 86.9% of all people with undiagnosed diabetes, that is live in low and middle income countries. Home to 4/5 of the world population. that is IDF 25, that is an estimated 589 million adults aged 22 to 79 years are living with diabetes. That is about 11.1% of world population. Total number of adults living with diabetes is predicted to rise to 13% by 2050. An estimated 252 million adults, that is 42.8%, aged 20 to 79 years, living with diabetes are unaware they have the conditions. So one in four adults living with diabetes are aged above 65. And over 3.4 million people died as a result of diabetes in 2024, that is 9.3% of global death from all causes. Nearly 1 in 10 of all death in age group 70 to 79. An estimated 1 in 5 live births are affected by some form of hyperglycemia in pregnancy. Type 1 diabetes, IDF 2025, that is estimated 9.1 million people are living with diabetes type 1. 22.3% of these living in low income and lower middle income countries. In 2024, there was 503,000 new cases, that is type 1 diabetes, diagnosed at all ages, with 219,000 of these new cases, that is 43.5% in children and young under 20 years. Number of people all ages live with type 1 diabetes, that is USA, and number of children and adults under 20 living type 1 in India also. In Indian context, the number of adults with diabetes 20 to 79, that is 89.8 million. Total number of adults living with diabetes is predicted rise, that is 156.7 million by 2050. Diabetes prevalence rate is 9.5 in India. Proportion of undiagnosed diabetes, that is 43%. India accounts for 1 in 7 all adults living with diabetes worldwide. Estimated death, that is about 0.33 million. These are the regulation of glucose homeostasis. And what the mechanism of glucose stimulated insulin secretion abnormality in diabetes, everyone knows. And what is the pathogenesis of diabetes? Type 1 diabetes, that is the interaction of a genetic, environmental and immunology factor led to immune-mediated destruction of pancreatic beta cell and insulin deficiency. Autoimmunity to islet. Autoimmune process is thought to be triggered by an infectious or environmental factors, that the autoantibody against islet cell antigen appear after this triggering event, followed by progressive loss of insulin secretion. Progressive beta cell destruction leading loss of insulin secretion. At the time of diabetes mellitus, 70 to 80% beta cell destruction has to occur. Type 1 diabetes, after the initial clinical presentation, a honeymoon phase, that is 1 to 2 years, that is glycemic control is achieved with modest dose of insulin or rarely insulin is required. That is, this fleeting phase of endogenous insulin production from residual beta cell disappear and individual become insulin deficient. This is the graphically presentation, that is stage 1, stage 2, where that is actually stage 1 is honeymoon phase, but when that is a destruction more than 70%, you will that diabetes will start. Type 1 diabetes, genetic susceptible. It is type 1 is multiple gene involved. That is identical twin, that is 30 to 70%. Major susceptibility gene located in the HLA region of chromosome 6, polymorphism in HLA complex accounts, that is for 50% of genetic risk of developing type 1. Predisposing genetic loci, these are the loci at a greater frequency with diabetes type 1. Protective HLA haplotype, DRB1, these are the, and more than 60 additional genetic loci contribute susceptibility. Polymorphism in the promoter region of the insulin gene, and CTLA4 gene, interleukin 2 receptor, and PTPN22. Risk of developing type 1 is increased in relatives. Risk of is relatively low, 1 to 9% if the parent has type 1 diabetes, 6 to 7% in a sibling. Type 1, that is pathophysiology, that lymphocyte infiltration to pancreatic islet cell, that is insulitis, seems inflammatory process leading to atrophy of islet cell. Study of the autoimmune process have identified the following abnormalities: islet cell autoantibody, activated lymphocyte in the islet and peripancreatic lymph nodes, T lymphocyte proliferation when stimulated with the islet protein, release of cytokines with the insulitis, that is the TNF alpha, interferon gamma, and IL-1. And beta cell is more susceptible to those cytokines by nitric oxide metabolites, apoptosis, and direct CD8 T cell cytotoxicity. Islet cell destruction mostly is a CD8 T cell mediated, that is cytotoxicity, not antibody mediated, because antibody does not react to cell surface of islet surface cell. Pancreatic islet molecules targeted by autoimmune process, that is proinsulin, insulin, glutamic acid decarboxylase, gut, islet antigen 2, biosynthetic enzymes, beta cell specific zinc transporter. New antigens produced during islet cell destruction, that is exacerbate the autoimmunity and series of beta cell destruction. Immunological markers, these are the insulin, gut, and IEA2, zinc transporter 8, commercially available insulin and gut. Except beta cell, other islet, that is alpha cell and delta cell, PP cell, these are not, these are spared from the autoimmune destruction. Alter pattern of hormone secretion, type 1 diabetes, develop metabolic instability. Alpha cell dysfunction is reflected by hyperglucagonemia in fasting prostaglandin state and impaired glucagon response through hypoglycemia. And these are environmental factors trigger that autoimmune process is in genetically susceptible individuals. That is virus, Coxsackie, rubella, and enterovirus, and bovine milk protein, nitrosuria, vitamin D deficiency, environmental toxin. These are the offending factors that initiate the autoimmune process. Type 2, that is genetic susceptibility, polygenic and multifactorial, identical twins, 70 to 90%. Both parents have type 2 diabetes, risk approach 70%. Environmental factor, obesity, poor nutrition, reduced physical activity, increasing age, socioeconomic status, later also gestation hyperglycemia may develop type 2. Polygenic, genetic loci more than 600, genetic polymorphism, the peroxisome proliferator activator receptor gamma, inward rectifying potassium channel, zinc transporter, IRS, and calpain 10. Definite genetic foci in type 2 diabetes predictive less than 10% only. So pathophysiology, impaired insulin secretion, insulin resistance, excessive hepatic glucose production, abnormal fat metabolism, systemic low-grade inflammation, so obesity, particularly visceral or central, as evidenced by the hip-waist ratio is very common, that is more than 80%. In the early stage, glucose tolerance test is normal because of pancreatic beta cell compensate by increasing insulin output. Insulin resistance and compensatory hyperinsulinemia progress the pancreatic islet are unable to sustain the hyperinsulinemic state further, manifesting as postprandial hyperglycemia. Glucagon overproduced and secreted, decline in insulin secretion, and an increase in hepatic glucose production leading later on fasting hyperglycemia. So newer classification, as per International Diabetes Federation, that is 2025, that is type 1 diabetes, everybody knows that immune mediated beta cell destruction, and type 2, that is also everybody knows. The type 3, some genetic factors, that is the genetic defective beta cell development and function characterized by mutation, that monogenic, that is Modi. So that is maturity onset diabetes, young, but the diagnosis is very less, and so many types of Modi, that is up to perhaps 14 types already been established, that is monogenic. So next is the neonatal diabetes, that is less than 6 months due to mutation, that is also under Modi, that is neonatal, transient neonatal diabetes. Diseases exocrine of the exocrine pancreas, pancreatitis, pancreatomy, neoplasm, cystic fibrosis, these are earlier was there, no changes. Then the genetic defects in insulin action, some syndromes are there, and endocrinopathy, everyone know acromegaly, Cushing, pheochromocytoma, glucogonoma, hypothyroidism, somatostatin, aldosteronism, and some drugs, glucocorticoid, and infection, like congenital rubella, cytomegalic abscesses, uncommon also immune-mediated diabetes. Okay, and fourth one is gestational, everybody knows. And the fifth one I only added that malnutrition related, that is 2025 perhaps is accepted, and that is by IDF. And malnutrition related diabetes represent a distinctive form diabetes, predominantly seen in tropical developing nations, with India bearing significant disease burden. These are the subtypes, that is fibrocalculopancreatic diabetes, well-defined entity, and another is protein deficient pancreatitis, the controversial entity. And FCPD in India, approximately 1 to 2% of diabetes. In southern Kerala, Karnataka, Tamil Nadu, it is higher, 5 to 10%. The condition predominantly affect male. Patient typically lower socioeconomically mostly affected. Onset is 10 to 30 years. And FCP, that is a pathophysiology, initial short childhood, malnutrition, micronutrient deficiency, potential environment toxin, oxidative stress, inadequate antioxidants, defense lead to free radical damage, chronic inflammation, fibrosis calcification, and dual insufficiency, both endocrine diabetes.
Sorry to disturb.
Okay.
Please wind up. Your time is up.
These are the zinc also, these are the factors. This one.
Dr. Rajesh Kumar Meher. Dr. Rajesh Kumar Meher is Junior Consultant in Department of Endocrinology, SCV Medical College, Cuttack. He has 2 publications in international journals. His topic today is early diagnosis, pre-diabetes, when and how to intervene, importance of HbA1c, of CGM, and time in range. Now it's your time, sir. Please keep to your time.
Good morning, everyone. Respected teachers, my seniors and friends. Today I am going to present about pre-diabetes. Am I audible? This will be discussed on the following headings. One is introduction of pre-diabetes, global and Indian burden, diagnostic criteria, then pathophysiology of pre-diabetes, screening strategies, early intervention approach, role of HbA1c and continuous glucose monitoring. Then coming to introduction, pre-diabetes or intermediate hyperglycemia is a bridge between normoglycemia and hyperglycemia, characterized by higher than normal blood glucose but not fulfilling the criteria for type 2 diabetes. Then why pre-diabetes is important? Individuals with pre-diabetes have 5 to 10% of increased risk of development of type 2 diabetes and are associated with increased microvascular complications like nephropathy, retinopathy, neuropathy, or macrovascular complications like cardiovascular disease, myocardial infarction, and stroke. Then what is the global and Indian burden? According to IDF 2024 data, 589 million of adults, that is 20 to 79 years, are living with diabetes globally. That is around 11.1% of global adult population. And the prevalence of impaired glucose tolerance and impaired fasting glucose in 2021, according to data, was 464 million, that is 9.1% of adult population, which is projected to increase around 638 million, that is around 10% of the population in 2045. And isolated impaired fasting glucose, that is IFG, was about 298 million in 2021, which is projected to increase about 414 million in 2045 globally. And according to ICMR India study, in 2024, around 100 million people are living with diabetes in India, and 136 million are with pre-diabetes. And the pre-diabetes pool is future diabetes burden. So, as pre-diabetes is reversible, early identification and management is important to decrease the burden of the disease. Then coming to the diagnostic criteria, pre-diabetes may be isolated impaired fasting glucose or isolated impaired glucose tolerance, or combination or both may be seen. And according to American Diabetes Association, the impaired fasting glucose based on the fasting plasma glucose value 100 to 125 milligram per deciliter, and definition of IGT, that is impaired glucose tolerance by 75 gram of glucose to our plasma glucose between 140 to 199 milligram per deciliter, and according to ADA, HbA1c cutoff is 5.7 to 6.4. But there is slightly different cutoff in impaired fasting glucose according to WHO, that is 110 to 125 milligram per deciliter fasting blood glucose. And impaired glucose tolerance according to WHO, blood glucose of 140 to 199 milligram per deciliter. They have not defined the criteria for HbA1c cutoff. And according to International Expert Committee, the HbA1c cutoff is 6.0 to 6.4%. There is slightly different cutoff, but we are following the ADA guideline correctly. Then coming to pathophysiology of pre-diabetes, insulin resistance along with beta cell failure is the main pathology mechanism. Due to insulin resistance, there is increased hepatic glucose output. Also, there is loss of fast-fed insulin secretion from pancreas is seen. Then next come to the pathophysiology of impaired fasting glucose. In liver, there is decreased liver insulin sensitivity, and in muscle level, there is normal muscle insulin sensitivity, and from pancreas, there is reduced fast-phase insulin secretion, and due to increased hepatic glucose output, there is elevated fasting plasma glucose, but due to normal muscle glucose insulin sensitivity, there is normal OGTT value. So, impaired fasting glucose is seen in this scenario, but in impaired glucose tolerance, there is normal or slightly reduced hepatic insulin sensitivity causing normal hepatic glucose output, but in muscle level there is reduced muscle insulin sensitivity, so OGTT is impaired in this case. And from pancreas there is reduced both first phase and second phase insulin secretion, so there is normal fasting plasma glucose with increased OGTT plasma glucose. Then whom to screen? People with obesity or overweight, if there is signs of insulin resistance like acanthosis nigricans, multiple skin tag, double chin, central obesity, with family history of diabetes, history of PCOS or gestational diabetes mellitus in female, or a history of hypertension, dyslipidemia, these people are high risk for development of pre-diabetes and diabetes, type 2 diabetes, so these people are the candidates for screening. Then coming to natural history of pre-diabetes, the patient with pre-diabetes 5 to 10% progress annually to frank type 2 diabetes. The microvascular damage begins early from the pre-diabetes stage, and cardiovascular risk also begins before the diagnosis, and there is a window of prevention or a window of opportunity exists, so this patient can be reverted back to normoglycemia if early intervention can be taken. So why early intervention is required in pre-diabetes? Early intervention in pre-diabetic stage reduces the progression of type 2 diabetes by 40 to 70%, and it also prevents the complication, both microvascular and macrovascular complication can be prevented, and it improves the beta cell preservation, and long-termly it benefits the patient, and it reduces the long-term healthcare cost due to diabetes and other comorbidities. Then management. Lifestyle intervention is the cornerstone of the management. It includes the dietary modification with physical exercise, which is shown to reduce the progression of pre-diabetes to type 2 diabetes in 40 to 70% of cases. There is different diabetes prevention program has shown lifestyle intervention prevents more conversion of pre-diabetes to type 2 diabetes as compared to metformin, and the disease or renal disease, like with pre-diabetes, we can use SGLT inhibitors like dapagliflozin or empagliflozin. Then after screening, the criteria for diagnosis of pre-diabetes, all the patients should be subjected to dietary modification with calorie restriction of around 700 kilocalorie per day, with weight loss of around 5 to 10 kg, physical exercise 150 minutes per week, moderate exercise with smoking cessation and sleep and improve sleep hygiene and stress reduction. If there is failed to achieve euglycemia after 3 to 6 months of prevention program, Japanese study, and Indian diabetes prevention program. All of them has shown there is prevention of type 2 diabetes in around 40 to 70% of pre-diabetes by lifestyle and diet modification, and these trials clearly shown that lifestyle intervention is better than any drugs, that is metformin or SGLT2 inhibitors or pioglitazone. The effects of the drugs mostly went some after 6 months of stoppage. So on long term, this lifestyle intervention is better, efficacious for prevention of type 2 diabetes. And other trials like diabetes prevention program with troglitazone, Gender's trial with early start, or Indian DPP study with metformin or pioglitazone, DREAM trial with rosiglitazone, and Navigator trial nataglinide with or valsartan with placebo, and SCALE trial with liraglutide versus placebo. These trials shown that none of the drugs is significantly helpful in prevention of type 2 diabetes, and most of the drug effect on long term that is slightly better than placebo, but not as much as beneficial as lifestyle intervention. So lifestyle intervention is must for all patients of pre-diabetes, and it is on long term it is beneficial for the patient. Then coming to the role of HbA1c. HbA1c should be done in HPLC method in a DCCT standardized lab. It reflects the 2 to 3 months of average glycemic status. It is convenient for the patient as there is no fasting required, but there is certain limitation, that is its value depends on the RBC turnover in GC-SPD deficiency, hemoglobinopathy like sickle cell disease, thalassemia, which are more prevalent in our belt, or advanced renal disease, history of blood transfusion in pregnancy. The HbA1c value may be falsely high or falsely low, so we cannot rely solely on HbA1c value. So it is not a very good test for the diagnosis in all patients, but it can be useful in follow-up monitoring for the patients. And limitation of HbA1c test, it doesn't show the glycemic variability and misses the postprandial spike, and hypoglycemia also not detected, and ethnic variability in HbA1c test is seen in different populations. Here, two patients A and B both have HbA1c of 8%, but see the glycemic variability in patient A. There is high glycemic variability. There is spike of glucose excursion followed by hypoglycemia, but HbA1c is 8. In patient B, there is low glycemic variability. Blood sugar is quite stable in patient 2. So this is the drawback of HbA1c. We cannot diagnose hypoglycemia and early preprandial postprandial peak by seeing simply HbA1c value. So there is high need of continuous glucose monitoring system. Then coming to CGM. CGM is continuous glucose monitoring. It detects the interstitial blood glucose as compared to SMBG, that is cell monitoring of blood glucose by glucometer or other value. We are seeing the capillary blood glucose value. And CGM machine, it detects the early postprandial spike, identify dysglycemia pattern, and hypoglycemia also detected by the CGM value, CGM machine. And the CGM is two types. One is intermittently scanned CGM, another is real-time CGM. The intermittently scanned CGM actively scans the sensor throughout the day, but real-time CGM, it continuously collects glucose data and transmits every 5 minutes. In the CGM machine, there are three parts. One is sensor, another is transmitter, and a smartphone or a device that receives the data is called receiver. The sensor and transmitter is one device that is inserted to the subcutaneous tissue, mostly the forearm of the patient, and it continuously measures the glucose level in the interstitial fluid. The transmitter transmits the glucose data to the receiver, and the smartphone device or any device which displays the glucose data is called receiver. The half-life of this sensor is around 7 to 14 days according to the manufacturer company. There are certain CGM metrics which we shall know. First is what is target range. Target range is blood sugar of between 70 to 180 milligram per deciliter. And target in range, that is TIR, Each percentage of time blood sugar is between 70 to 180 milligram per deciliter. It is called target in range. Above range is blood sugar of more than 180 milligram per deciliter. If blood sugar is between 181 to 250 milligram per deciliter, it is called level 1 hyperglycemia, and level 2 hyperglycemia is defined as blood sugar of more than 250 milligram per deciliter. And below range is blood sugar of less than 70. If blood sugar between 54 to 69 milligram per deciliter, it is called level 1 hypoglycemia. And if blood sugar is less than 54, that is called level 2 hypoglycemia. And our target is in TIR, that is target in range, it should be more than 70% of time. And target above range, it should be less than 25% of time. Blood sugar should be more than 180 milligram per deciliter. And target below range, blood sugar less than 70%, it should be achieved less than 4% of the time. And another important thing is glycemic variability. It is defined as the standard deviation of the mean plasma glucose throughout the 24 hours divided by mean plasma glucose around 24 hours. It should be less than 36%. If glycemic variability is less than 36%, it is called as stable glycemic control. If glycemic variability is more than 36%, it is called unstable glycemic control.
So next topic of discussion is individual glycemic target. Current
Questions will be in the end.
कौन करे? Okay, we will be discussing questions later on after completion of 3 speakers. So next topic of discussion is individual glycemic target, current treatment algorithm in type 2 diabetes mellitus, and he will be covering ADA, ESAD, RSSDI guideline. This is the important topic to discuss because whenever we come across patient of diabetes mellitus with complication, if we will ask whether why you have not started yet your treatment. So patient will obviously say, Madam, I am on treatment since long. But what is the fault? Most probably they are not approaching the target level of HbA1c that is around or less or equal to 7%, and they are not adhering to the other mode of treatment apart from OHA, insulin, and lifestyle modification, exercise, and balance health status and diet. So that's why now speaker is none other than Dr. Siddharth Shankar Panigrai. He was happened to be my student. He's very good student, and now he is working as assistant professor, Department of Endocrinology and Metabolism in IMS and SOM Hospital, Bhubaneswar. And he has 5 publications and 5 book chapters in his credit. So Siddharth, please start your talk and please complete within time. Thank you.
Thank you, ma'am. This is my own teacher. And thank you, Dinabandhu sir, for giving me this opportunity. And respected chairperson sir, Sahu sir, Bansal sir, and Agarwal sir. So my topic for today is the individual glycemic targets. What are the current treatment algorithm, and what does the various different bodies says, like the American Diabetic Association and the European Association and RSSDI. So the very first thing, why do we need a guideline? So whenever it starts, while managing a hyperglycemia, we have so much of options. We have, very first we have insulin, then the OAD came, then after the OAD, some cardioprotective and the renoprotective drugs came, and so many other drugs. We are all confused how to start these agents, and that's why we need a guideline. So what does a guideline says? That we control everything. We control the organ risk, we control the person-specific risk, we control the glucocentric risk, and we move in the same direction, and that's why the guideline helps us. And then we make a tool, an algorithm, which helps us to treat the patient. So this is the history of all the guidelines. The very first guideline was glucocentric, that is the ADA standard of care evolution at 1989. It was glucocentric. And then we started our therapy based on HbA1c, and metformin became the first line. This was around 1995. And then so many drugs came, the armament started increasing. We have thiazolidinediones, DPP-4 inhibitor, basal insulin, and analogs came. And then in the last decade, we have the CBO2 revolution era. We came across SGLT inhibitor and GLP-1 analog. And now, when we started seeing the heterogeneity of the disease, the heterogeneity of the microvascular and the macrovascular complication, a concept of precision medicine has come. So that is the evolution of the guideline in the last 30 years. So the very first thing that we need to know, what is the rationale of all these guidelines? So the rationale of all guidelines, like, do we need an intensive glycemic management? Is weight loss that important? How we are going to manage the CKD progression, control the CVD risk, control the hospitalization due to CVD and heart failure, and also minimize hypoglycemic risk. So this is the very first study that was done in the last decade, and it was very famous. All of us know the EMPA-REG study, the DECLARE-TIMI study involving empagliflozin and dapagliflozin, and how it has reduced the major adverse cardiac event, that is MACE, by 14%. In terms of empagliflozin, CV death has been reduced by 38%, heart failure hospitalization reduced by 35%, and renal composite outcome has been reduced by 39%. In case of dapagliflozin, we didn't get a significant result in terms of CV death and MACE event, but heart failure and renal composite outcomes, we found a significant result. Similarly, whenever it comes to GLP-1 analog, we have the LEADER trial with liraglutide, the SUSTAIN-6 semaglutide, and the REWIND trial with dulaglutide. All we have got a significant reduction in the MACE outcome. And there is a decrease in the event with an hazard ratio, as you can see in the screen. And then SGLT inhibitor has been shown to minimize the CKD progression. That is, the DAPA-CKD trial has shown that it decreases the progression by 39%. That is the rate of decrease of EGFR by more than 40%. And the EMPA kidney trial, we got a reduction by 28%. And then we have two very interesting trials, that is the Look Ahead trial and the Direct trial, where we have only studied weight loss effect on HbA1c reduction in patients with pre-diabetes and obesity or mild hypoglycemia, and we have seen that there is a drastic reduction in HbA1c, like 0.6% in Look Ahead trial, and the Direct trial we have 0.9% reduction. So with all these things, our concept has changed from a lower glucose, like a glucocentric target, to a risk-centric, person-centered, and organ-centric approach. So why do we need this approach? What is an individual approach? So like I have mentioned, we need to mention hyperglycemia. We need to control CV risk, renal, and also check the social and the personal parameter of the patient. And weight loss has become an important cornerstone of management. And that is why we need a holistic approach. So we have to minimize hypoglycemia risk, like it is more common in elderly, patient with CKDs, elderly patient with long-standing duration of disease. We need to avoid a complex regimen risk, that is avoiding polypharmacy. We have to maintain the adherence and the compliance of the drugs. Also manage other comorbidity like CKD, CVD. Also manage how the patients are going to take drugs whenever they have dementia. And there is a disease variability, like as sir has mentioned, there is a polygenic background of the disease, and that's why there is heterogeneity. And that's why we have to see, that's why the precision medicine has come up. So that's why we need an individual approach for all the patients with diabetes. So all these guidelines help us to know how to start OADs, how to start insulin, when to start OADs. So what are the glycemic targets? So these are the very, very landmark trial. UKPDS, Accord, Advance, the Steno-2 trial, the Kumamoto trial, all of them have targeted an intensive glucose control. Their HbA1c target was 7%, 6%, as you can see in the screen. And what they have got? The UKPDS trial was famous for its concept of legacy effect, that is the metabolic memory, where we see that early control minimizes the microvascular risk, and then those early control years will help to minimize the macrovascular risk later on in the disease duration. Likewise, the Accord trial, they were very much aggressive with their approach, and that's why there was an all-cause mortality increase with the Accord trial whenever they went for a very aggressive glycemic control. And so, we have the Steno-2 trial, which has a multifactorial approach that meets our demand of a multifactorial approach where we target hypertension, we target albuminuria, and that's why there was a decrease in 50% in CV risk in the Steno-2 trial. And then we have the Kumamoto trial where they have maintained a HbA1c target of 7.1%, and we have seen it drastically and significantly decreases the risk of nephropathy and retinopathy. And so, as I have mentioned in the last slide, immediate microvascular risk reduction, UKPDS has shown, and late benefit for macrovascular, again UKPDS, and one type 1 DM study, that is the DCCT trial, has shown, and multifactorial approach we have seen with Steno-2 trial. And so, the ADA and the European Association advises a very standard glycemic target of A1C level less than 7%, a preprandial plasma glucose of 80 to 130, and a postprandial peak plasma glucose of less than 180. So this is the standard glycemic target for all adults and non-pregnant female. But the issue is that a single glycemic target cannot safely or effectively apply to all the patients. And so ADA and both European Association and target is still okay as advised by ADA and European Association. As advised by ADA and European Association. But RSSDI advises us for a standard HbA1c target that is less than 7%. It is a straightforward target for all the patients, but side by side it also recommends a bit of relaxed HbA1c target of 7.5 to 8%, even sometimes more than 8% for high risk individual having multiple comorbidity and elderly. And if we reach somehow an HbA1c target below 6.5%, it advises us to de-intensify the treatment, and that's why it gives a less emphasis on aggressive lowering of blood sugar level. So why less aggressive targets for Indians? The issue is that we have a real world hypoglycemic risk. Our patients, first of all, they are not compliant to diet. Second, either there are so many religious issues, patients are sometimes fasting, and even if people are diagnosed with diabetes, they don't come to physician, and sometimes they are diagnosed less. And still now the usage of sulfonylurea is very common in India, and that's why we need to have a lesser aggressive targets. And we have a resource issue. There is as Rajesh has mentioned earlier about CGM, very few people in India has got an access to the CGM technology. And even SMBG we are struggling to advise because people are not able to follow a regular SMBG monitoring. And still so many people, even if they are able to manage their sugar properly, we are still not able to follow up them regularly for any risk of comorbidities. And that's why we need a lesser aggressive targets in Indian population. This is the CGM targets by ADA. As you can see, in healthy older adult, we have a HbA1c goal of less than 7% with a time below range of 4% and a time above range of less than 25%. As you can see in the rightward column, it has been relaxed for the elderly patient with complex diseases with a time below range decreased to less than 1%. Time above range has been advised flexibly to less than 50%. So how to monitor the glycemic control? As advised by all the bodies, HbA1c should be done twice yearly in stable patients and every 3 months in patients where we are changing the therapies or patients are not meeting the goal or their glycemic status are very unstable. But whenever it comes to CGM, ADA advises it for type 1 DM, type 2 DM who are either on insulin or even not on insulin. And it has become very common in US and Canada. But in terms of Indian scenario, it has been advised by RSSDI to be used in type 1 DM, type 2 DM individual treated with intensive insulin therapy, needing at least more than or equal to 4 injections daily, and still not achieving the glycemic targets. Coming to management. So ADA approach was more of like a comorbidity driven, organ protective and person centered care. But whenever it comes to Indian scenario, we have got different phenotypes and we have cost issues, affordability issues. So RSSDI advises a phenotype based, cost sensitive and resource appropriate care. We'll come to the phenotype thing shortly. So ADA therapy is based on the presence or absence of any CVD risk, heart failure, CKD, patients with hypoglycemic risk, weight loss as a major criteria, and life expectancy. Whereas RSSDI, it focuses more on Indian phenotype, that is lean diabetic having proven to have an early beta cell failure, or there has been equal proportion of lean and both obese phenotype, and also patient socio-economic status and multiple comorbidities. So these are the drugs, as you can see, and everybody is familiar here with this, like metformin, it has a weight neutral benefit, but it has got a benefit in terms of MACE and heart failure. GLP-1 analog in last decades has been proved beneficial in decreasing the MACE event and weight loss. GLP-1 analog plus GIP analog, newer drug tirzepatide has come. It has got the maximal weight loss of 20% with a MACE benefit. And in terms of CKD, it has got benefit in terms of decreasing the albuminuria. SGLT inhibitor like the DAPA CKD trial and the EMPIREC trial, they have got a weight loss of only 3 to 4%, but it has got a major benefit for MACE event and heart failure hospitalization. Pioglitazone in Indian scenario, it decreases the metabolic stress of the beta cell, and that is why early combination therapy including a pioglitazone is helpful in Indian scenario. And insulin, it has got a side effect of weight gain like sulfonylurea. Normally we use it whenever the HbA1c goes below 10% or a random blood sugar is more than 300, or there are catabolic and osmotic symptoms, or in hospital scenario. So this is the ADA recent 2026 guideline based on the ASCVD event. GLP receptor analog, we have liraglutide and semaglutide, or the SGLT inhibitor are the first line, first choice as per the ADA. And if glycemic controls are not achieved, we can still go for a combination therapy, including either SGLT plus GLP or GLP plus SGLT, whichever we can add later on. Whenever it comes to the CKD patients, we can add again the same. We can start with an SGLT inhibitor, or we can add a GLP receptor analog. That is what ADA emphasis on. And similarly, if there is no comorbidity, still we can go for metformin, or if we are targeting a weight management, again GLP receptor analog, recently semaglutide and tirzepatide can be used. But in terms of RSSDI, throughout last 10 years, metformin has been shown as the first line therapy in Indian patients. And if contraindicated, then only we should think of starting sulfonylurea, pioglitazone, DPP-4 inhibitor, SGLT2 inhibitor. And one of the major issue of Indian patients are the postprandial hyperglycemia. Like everybody might have faced that we have patients with a fasting plasma glucose of 90, 110, but a postprandial sugar of 250 or 300. And that is very common in Indian scenario. And that is why a combination therapy with alpha glucosidase inhibitor repaglinides or SGLT inhibitor or a bolus insulin can be used. Even DPP-4 inhibitor also can be used if not contraindicated along with metformin. So this is the combination therapy when to start as per the ADA. If the HbA1c level has increased by more than 1.5% above the target, or the HbA1c level is above 10%, we can go for a combination therapy, either OADs, or it goes more than 10% insulin or combination, and based on all the comorbidity, we can add drugs. Likewise, for RSSDI also same 1.5%, but we have to start early to prevent beta cell loss. We have seen GLP receptor analog and pioglitazone. It helps protect beta cell. So this is the ABCD approach of RSSDI. It is available with RSSDI recent guideline of 2022 how to approach this. And summarizing the treatment, ADA metformin is preferred but may not be the first line. We should start with SGLT inhibitor or GLP receptor analog. For RSSDI, metformin is mandatory, and later we can add those drugs. And this is the comparative analysis. Like mostly the RSSDI, it is a phenotype and cost driven. Metformin is always the first line, but in ADA it is preferred but not mandatory as a first line. GLP receptor analog, there is an affordability issues. SGLT inhibitor, we can still add on after metformin. DPP-4 inhibitor are commonly used because of their affordability. Alpha glucosidase inhibitor, due to control the postprandial glycemic surge, we can use. That's why it is important. Sulfonylurea, most commonly used in Indian scenario. That is why it is advised by RSSDI. But ADA de-emphasizes sulfonylurea due to risk of hypoglycemia. Insulin, we can use basal insulin as per ADA, but RSSDI advises a premix insulin because of affordability and cost issue. And weight reduction is still as a secondary consideration for RSSDI, whereas for ADA it is a primary consideration. So why there is a PPG?
1 year and 5% for diabetes. So we have to catch pre-diabetes earlier. So what screening methods are validated to diagnose pre-diabetes in mass screening if you are doing the RBS only? So you have any idea? One I know, NFHS. They have got the criteria. If somebody's random blood sugar is more than 140 to 160, they take it as pre-diabetes. Subjected to next day they will do the test fasting. So are there any other tests, any other such studies you know of? Because we have to screen our people with random blood sugar, which is most convenient for our person who are attending our clinic or in society. So is there any criteria for that?
Actually, still now, after random blood sugar, OGTT has been studied in multiple trials, multiple studies. They have done OGTT. After getting a random sugar of like more than 140, the next day they have done OGTT. Based on that, only they have like screened the patient. Like I'm talking about like European and American studies.
Sir, in such cases, it is difficult to examine fasting state and the blood sugar is more than 100 but less than 110.
Sir, I am asking about mass screening.
Sir, that is what I am saying. In mass screening, the patient may turn up in the fasting state, may turn up after, any time after food. If it turns up any time after food and it is a random sample, then the blood sugar above 140 and less than 199 should be kept for subsequent tests like one time glucose test for diagnosis.
Another question, Dr. Panigrahi. AGIs are not so popular in Western countries. So why is it so? Do they don't have this postprandial hyperglycemia there? Because I have always wondered why AGIs are not popular in Western countries. How do they manage their postprandial? Because their A1C, standard A1C is also pretty high. In spite of treatment, it's around 8.5. That means it must be their postprandial is always high. So what, if you have any idea, because we are managing only Indian patients, but do you have any idea why, how they are managing their postprandial? Is it only exercise or something else? Or their food?
Actually, in Indian scenario, AGI is an affordable drug. In case of European and American population, they are controlling their postprandial. First of all, they are going for a early initiation of insulin, a shorter acting, or they are using like DPP-4 inhibitor or like SGLT inhibitor. But they are not much using ovulose or carbon. Indian scenario, it is still advised because we have a discrepancy. Fasting may be within the range, but the postprandial sugar is very high, and that is why we are using. But in European and American scenario, we have a proportional increase in both fasting and postprandial, and that is why a drug which targets both can be used. Or even though they are going to target the postprandial sugar, they are using more of like SGLT inhibitor or short-acting DPP-4 inhibitor. We have telling or major difference.
Can it be like we Indians, Southeast Asians are more of carb rich diet, whereas Western diet is more of protein.
Yes, sir. Yes, sir. Like our diet is rich.
Because AGI will basically.
Yes, sir.
Then move on. Sir.
So, we thank all the three speakers for the nice concern and we proceed for the second session.
loss with early diagnosis and treatment algorithm of diabetes. Now I request all the speaker and the chairperson to gather near the memento stage and collect the mementos. I request Dr. Jayant Kumar Panda sir and Dr. Kabiraj sir to give the mementos. I now request Dr. Jayant Panda sir and Dr. Kabiraj Chaudhary sir to give the mementos.
Now, let's start the plenary session 2. I would like to invite Dr. Ramesh Chandra Pathak.
Oh, welcome to second session of this conference. And yeah, the first topic will be management of diabetes in young type 1 DM, MODY and decay. And to speak for this, our guest is none other Dr. Chandan Das. I have heard him in many conferences. He is a very energetic speaker and he is a very precise speaker. To introduce him for others, he is former Associate Professor, High Tech Medical College, Bhubaneswar, Joint Organizing Secretary, AKN Odisha 2015, one of the designated ADA instructor for India and awarded with the Rajiv Gandhi Young Indian Award in 2010. I think he is the best person to speak about this subject, and I will request him to start his session now.
Good morning. Thank you, chairpersons. And much depleted hall after these power breakups, but I will try to justify my topic. Initially, they have given me as a comprehensive management of pediatric type 1 diabetes and MODY and decay. Later on, they changed it to young type 2. Anyway, I will try to combine both.
Professor Chandan, just a minute. I request all of you who are standing behind please come and have your seat. Please have a seat. Start.
Thank you, chairpersons. So, when we talk about diabetes in young, we must know what is the type of diabetes. If it's type 1, how to know that it's a type 1 diabetes? The patient has to be lean. I'll try to make it a little brief because of short of time. When you suspect type 1 in a young individual, young means, if somebody is less than 25 years, when a patient is very lean, in its acute onset of high blood sugar and decay, diabetic ketoacidosis as presentation, which happens to around 30 to 40% individuals, and autoimmune markers are positive like GAD. There are so many autoimmune markers. The most common autoimmune marker which you do in our setting is GAD65. And another very important, very popular examination, very popular test is C-peptide. Sometimes it is little misleading, but yes, C-peptide can be done by you in a peripheral setups. So if low C-peptide or absent C-peptide, this is almost a diagnostic thing for type 1. Now, what about type 2? Is type 2 happening only in people who are more than 40 years? No. Type 2 diabetes in young. Young means less than 25 years. Type 2 diabetes is increasing in India. Then around I think around 9 to 10% people in India are having young type 2 diabetes before 25. And those patients are very conspicuous. They are very obese, their BMI will be high. They'll show all the features of insulin resistance like acanthosis nigricans, PCOD. They will have a very strong family history, at least a first degree family. And they will always have a very normal C-peptide levels, and auto antibodies will be negative as expected. Now, I told you the incidence of type 2 diabetes in population under 25 years in India is around 9.8%. And RSSDI recommends to screen for type 2 diabetes in young individual, also in children and adolescents, if they are obese plus at least one risk factor, that is with a very strong family history, or the patient has a maternal diabetes, the mother had GDM during his time, signs of insulin resistance which I have described, and if the patient has hypertension, then you have to screen for type 2 diabetes even if the patient is in childhood or in adolescence. Now, MODY they have added later, that was not there in the initial thing which they have given me. MODY is, you suspect MODY is a monogenic diabetes. You know about monogenic diabetes, maturity onset diabetes in young. They are typically seen in non-obese individuals. They'll have a very strong autosomal dominant family history. At least 3 generations. More than 2 generations has to be affected to call it MODY, because they have autosomal dominant. They will never have ketosis, but they will always have a very mild, stable hyperglycemia, though some varieties they will have progressive hyperglycemia. We'll talk about that later. And they will not have autoantibodies, that C-peptide levels will be preserved. Modi in India are underreported, but they're around 1 to 2%. The global incidence is around 1 to 5%. In India is 1 to 2%. Among the Modis, there's so many. I think Modi 3, that is HNFA1, that's a genetic defect which is found in Modi 3. They are commonest. That's globally they are commonest. And most of them are incidentally diagnosed. And they are wrongly diagnosed also, most of the time. They are wrongly diagnosed as type 1 diabetes and type 2 diabetes. So be careful. Stable blood sugar levels, not very high. With genetic tests, of course, genetic test doesn't come under gamuts of your place, but yes, they need genetic testing. But C-peptide and autoantibodies are going to help, right? These are the common Modi's phenotypes, subtypes. Now, let's come to the next topic. That is treatment of type 1 diabetes in India. Insulin, nothing else. No oral agents are allowed. What is the goal of our therapy? Have a normal glycemia, prevent acute complications like decay and hypoglycemias, then prevent long-term microvascular complications, and normal growth and puberty in younger individuals, in childhood and adolescent patients. Now, insulin management, when to start insulin? Anytime you diagnose type 1 diabetes, you start insulin. Immediately at diagnosis. Then, of course, they present, I told you, around 40% present with decay in type 1 diabetes patients. So, them you treat immediately after resolution of decay, you have to start subcutaneous insulin. And, of course, there is no role of oral agents. Now, initial total daily dose is pre-pubertal are little 0.5 to 0.7 units per kg per day. Puberty, you may have to increase a bit. Honeymoon phase, you know about honeymoon phase. There has to be a little less, 0.3 to 0.5 units per kg per day. And you have to adjust, you have to titrate the dose. It's very difficult to titrate the dose in type 1 diabetes. I'll tell you how it is, why it is difficult. 40 to 50% dose has to be basal insulin. And rest of there has to be bolus insulin. And the basal insulin options are, of course, if you patient can afford a degludec is a ultra long acting insulin, that is preferred, but it's little expensive, but then you can go for detamir and all. Bolus options are, you have short acting insulins like glulysin, aspart and all. Dose distribution example, I mean, what should be the dose? The dose I told, suppose a 25 kilo child, it is 0.6, that is 0.6 units per kg. That is 25 kilo means around 15 units per day of insulin will be required in that person, roughly. I'll tell you what are the other twists in that. Out of that, 50% means around 40% means around 7% will be basal and 8% will be bolus. Now, dose adjustment principles, they has to be followed up 2 to 3 days based on self-monitoring blood glucose trends. Of course, there is a 1800 rule correction factor. I'll tell you what is that. Then they have to calculate something called insulin to carb ratio calculation, right? Then what is this rule for 500? That is insulin to carb ratio calculation. That is 500 divided by the total dose required in a day. That if that is in grams, that will be covered by 1 unit. What do you mean by that? For example, 500. Suppose the patient is total dose requirement is 50 units, right? And 500 by 50 means 100 grams per unit. That means if you calculate the carb, like suppose we have to give 60 gram carbohydrate to that person additional, you have to give 60 units more. Or if you want to give 600 grams of carbohydrate to that person, you have to give 60 units, like that. Like that you have to calculate. Now, what is the correction factor? That is, or insulin's factor, that is rule of 800. That is a rule for short-acting analogs. Of course, for regular insulin, that rule is 1500 rule, where it is 1800 divided by the total dose of insulin required. That is the amount of glucose that will be dropped per unit of insulin. That means if you give, in this patient, suppose the patient total dose requirement is 15, that is 120 milligram of sugar will be reduced by 1 unit of insulin. This is how you have to calculate. So a lot of calculation. I tell you, friends, it is very difficult to adjust the dose of type 1 diabetes. I always say, mazak mein, that if you are not very happy with one of your endocrinologist friend or doctor friend, you send them type 1 diabetes patients. Okay, their career will be in jeopardy. It's so difficult to manage a type 1 diabetes patient. The glycemic targets are defined. Pre-meal target is 90 to 130 milligram per deciliter. Bedtime it has to be 100 to 140. The HbA1c target is less than 7. Absolutely difficult to obtain this target in type 1. Monitoring has to be, if it's a CGM that's very fine, HbA1c level has to be monitored every 3 months, and you have to look at the growth and puberty, because that time also you have to adjust, titrate the doses of insulin. Now technology is important, that time in range has to be more than 75. You don't know about it. I think with short of time we'll sick day protocol. There's something called sick day protocol. If a type 1 diabetes patient on insulin is sick of many, whatever reasons, fever, vomiting, whatever, don't stop insulin. That is dictum. Don't stop insulin. Do not at least continue the full dose of basal insulin. Basal insulin should be continued. Bolus, the bolus insulin can be, we can change the bolus. You can look at the glucose every 4 hours, and if the glucose is more than 250, check for ketones, because that patient is very prone. These patients are very prone for ketosis. We have to maintain hydration, and correction doses if blood glucose is 250 to 300 has to be given. As I have seen, we have to give correction doses a little lesser dose, because the patient is not eating anything. But don't stop insulin. That's the most common thing people do. Hypoglycemia management, I think I will not waste time in that. Very severe hypoglycemia, I need to hospitalize the patient. Severe hypoglycemia means that somebody needs hospitalization for management. And treatment of MODY at a glance, I think we'll not go in detail. I told you MODY 3 is the most common type of MODY, where you will find progressive hyperglycemia. But the good thing is they are very sensitive to low dose sulfonylureas. They are managed by low dose. Later they may require insulin after a long time, but they are initially can be managed with, but very good responsive to low dose sulfonylureas. MODY type 2, usually no treatment is required, treat only with insulin only when during pregnancy, but sometimes we may have to treat them. And MODY type 1, again sulfonylurea is a first line drug. And let's come to the third topic which has been given to me. Topic has been jam-packed into my... Third topic is decay, how to manage a decay in peripheral setup. We'll discuss about peripheral setups. Now, the diagnostic criteria of decay is glucose more than 200 milligram per deciliter in children, because my talk also includes children. In adults, it's maybe more than 250. In children, it would be, if it's more than 200, then the pH has to be, ABG has to be, is a must. In whatever setup you are working, without ABG estimation, you cannot treat a decay patient. pH has to be less than 7.3. Bicarb has to be less than 15 millimoles per liter. In children, less than 18 millimeters in adults. That's revised later. It's 18. Now they're telling 18. They have to be ketone positive, but very misleading. I told you. This ketone, urinary ketone is acetoacetate. But most important is beta-hydroxybutyric acid, which is found in blood. This is very difficult to estimate in your setup. But you have to go for whatever is available. Urinary ketone are one of the important thing. High anion gam metabolic acidosis, you have to calculate the high anion gam. It's by definition, it is more than 10 to 12 to call it a diabetic ketoacidosis. Initial stabilization, airway, etc., oxygen, monitoring IV lines, because IV lines, IV fluids are the paramount importance. Then comes insulin. First is fluid, right? The fluid management is the most critical step in the management of decay, where the blood has to, the fluid has to be 10 to 12 ml per kg of normal saline. Bolus has to be given. In children, I'm talking about in children, in the first hour, 20 to 20 ml per kg normal saline bolus. In adults, is it 15 to 20 ml per kg in the first hour? That is roughly around 1 to 1.5 liters in first hour. But if corrected sodium is low, you have to calculate a formula. There's a formula called corrected sodium calculation. I'll tell you if you are very interested in the background after that, because running short of time, you have to calculate the corrected sodium, because the blood sugar is high, the sodium will be falsely low. So if the corrected sodium is low, continue with a normal saline that is 0.9%, and when it's high, it's switched to 0.45 semi-nor or half-nor saline. That is around, the correction dose after 1 hour is 250 to 500 ml per hour. Don't try to overcorrect, especially in children, because they are very, in children, the pediatric type 1 diabetes with decay is very dangerous, because they are more prone for cerebral edema. So overcorrection is always a problem. Replace deficit over 36 to 48 hours. Do not become very overzealous in administration of fluid. Take 36 to 48 hours for correction. And you have to add glucose when the glucose levels are dextrose. Add dextrose when the glucose levels are less than 250 250 milligram per deciliter. But don't stop saline during addition of this glucose infusions. Insulin therapy, step 1, first hour. Don't give insulin unless you resuscitate with fluid for 1 hour. Insulin, the role of insulin comes after 1 hour. The IV infusions has to be given 0.5 to 0.05 to 0.01 units per kg per hour. In adults, it's little more. In children, this is little less. No insulin bolus is recommended now. It is optional. If you correctly start insulin in a proper infusion pump, you need not give an insulin bolus, which previously was advocated. Aim glucose fall of 50 to 100 milligram per deciliter per hour. And with this amount of insulin, your glucose fall has to be in this order. If the glucose is not falling in this order, then you have to escalate the dose of insulin bit high. Now patient is how to make a transition to subcutaneous insulin. Most important thing in your setup is when patient starts eating, the vomiting is stopped, patient starts eating, he is not dehydrated, acidosis is resolved. You have to see the anion gap. If the anion gap is closing, then we are reaching at your target. Patient has to be hemodynamically stable. Bicarb level has to be more than 15 to 80 millimoles per liter. And the most important thing is, give a basal fast before stopping the IV insulins. First, long-acting basal insulin 2 hours before stopping the IV insulin. Then after 2 hours, you can stop IV insulin. You can give the subcutaneous bolus insulins once the patient starts eating. Potassium is very important. I told you the total potassium deficit happened because the insulin is not there. It's an insulin deficient state. Potassium comes out of the cell and it may be diluted, it may go out. So even if the potassium looks normal, in the normal level, the body potassium levels are very less. So it is very important, this is a very critical step. If potassium levels are less than 3.3, you have to correct this potassium before starting insulin. You have to correct this potassium by 20 to 30 milligrams per hour. You give that amount of insulin that amount of potassium in the fluid. Once it reaches something between 3.3 to 5.2, you can start insulin. Otherwise, don't start insulin. If potassium levels are between 3.3 to 5.2, you can start insulin, but you have to add 20 to 30 milligrams per potassium in each liter of fluid. Right? If it's more than 5.2, straight away start insulin. No need to give any IV infusion potassium. Continuous ECG monitoring is important. Bicarbonate correction is not recommended unless the pH is less than 6.9, because the bicarb will definitely increase the acidosis of intercellular acidosis. That will be fatal. So don't give bicarb just looking at the pH level. If it's less than 6, you have to give bicarb. Otherwise, it's not required. Recognizing children and headache, irritability, bradycardia, hypertension, all these things. If you suspect cerebral edema, you have to give mannitol, you have to elevate the head, reduce IV fluids, ICU monitoring has to be done. Then resolution and transition. If pH is more than 7.3, bicarb is more than 15, anion gap is closed, overlap IV insulin with subcutaneous insulin 1 hour, resume basal bolus regimen, which we have already discussed. Now, the take-home message is, this is take-home message for decay, not for all. Protocol-driven decay management saves life. Avoid rapid correction of it, especially in children and adolescents. Basal bolus is the gold standard, not to reduce the progression to decay. Education prevents recurrence. Education to the patient, to the paramedics, even to your fellow doctors. That is important because decay is sometimes very, very fatal. Thank you very much.
Thank you, sir.
Thank you. That was a very short, sweet and informative presentation by Dr. Chandan.
Sir, just one announcement, sir. Actually, we need 5-minute break. We need 5-minute break to resolve the issue of electricity. Some technical problem is there. Then after 5 minutes, we will be re-available. Please cooperate.
Nowadays, some research shows intranasal glucagon is used. So I want to know what is the effectiveness and what is the role of intranasal glucagon over
glucagon
yes
in
hypoglycemia.
Hypoglycemia.
Yeah.
Glucagon is recommended in severe hypoglycemia when it is not improving with IV glucose dextrose. About intranasal, I think it has been recommended many people, but you don't get it in India. Are you getting it in India, intranasal glucagon? You don't have that facility in India. Yes, it can be used. Glucagon is recommended. One of the recommendation in severe hypoglycemia when it's not improving with IV dextrose is glucagon. Yes.
This shows that like over the IM glucagon and intranasal glucagon is more, but I don't know.
I have very less idea about that. I think sir will tell you better.
We will just like to discuss this because in type 1 diabetes, there is a role of glucagon. In type 2 diabetes, there is already hyperglucemia. So only treatment is dextrose, dextrose and dextrose. Nothing else. Type 1 diabetes, yes, you give glucagon as well. We have IV available. You can use IV. You can give intranasal also if available. But it's type 1 only. Type 2 diabetes, no.
Because there is no insulin, no glucagon in type 1. So you may have to, that may improve. Even in pancreatic diabetes also there is no glucagon. So you may have to give glucagon in those patients. Yes.
Thank you, Dr. Chandan, for a nice disposition on the young diabetes. This is not a question, this is a comment. I'll just tell our finding from Young Diabetes Registry, SCV Medical College, which exactly does what you presented. The type 1, the type 2 young, the moody, the LADA, and one more type that I'll love to include is the type 5. We are getting good number of patients, at least 12 patients in last 6 months we got, who are low BMI, less than 19 BMI, at the same time good insulin reserve, very well to oral drugs. And that was previously designated MRDM, and now they have come under type 5 group.
Yes, sir.
Thank you.
The Kotak story.
Yeah,
The famous
Kotak story.
Kotak story.
Kotak story, yeah. So we have 5 minutes break, then again we are coming back here.